But our next speaker, I think you're going to find very interesting. It's my colleague and friend in our division. It's Dr. Sara Edwards. Dr. Edwards is assistant professor of surgery at UC San Diego. She's a trauma surgeon, surgical intensivist, general surgeon. And she has a particular interest in surgical critical care and palliation of ICU patients, which is a new area for surgeons. It's now possible for surgeons to become certified in palliative care, and it's becoming a very important area of study, because since we realize how many patients end their lives in the ICU, sometimes as trauma patients. So I hope that you'll give her a big hand as she comes up, and we'll get her underway here.
Good morning. Does anyone need to stand up and shake it out, or are you guys okay? Everybody good? All right. So we're going to shift gears pretty dramatically, but I want to encourage you to think about what we talk about now as just as integral as conversations about airway. So we won't talk so much about death, because I think really the fundamental aspects of palliation, palliative care, and really whole patient care are about the life of the patient, not about their death. I have no disclosures, except that I really enjoy this topic. So we're going to start a little bit and talk about palliative care and intensive care and where those two care pathways intersect. We'll talk about some national guidelines that have come out that really impact how we deliver care. We'll talk about the concept of whole patient care and who needs to be involved. And then I'll give you some resources that I've found to be useful. So I'm just going to start with some definitions. Intensive care. So in general, right, we talk about medical and related procedures that are provided to patients with serious life-threatening or terminal illnesses. Interestingly, this is the beginning of the definition of palliative care, because intensive care and palliative care happen at the same time. So while we're treating for cure, we are also addressing palliative care. Palliative care is really about caring for the whole patient. So not just the pathophysiology of disease, but the person who's experiencing the injury or illness. And if you've seen this graphic before, I like to remind people that it's not just about people who are imminently going to die in the hospital, but also those who may have a prolonged course of recovery. The palliative care is not just for people who die, but for people who live. So to talk about our national guidelines, I'd like to first start with another definition, the definition of dignity. It's about quality of being, worthy of honor and respect. So what does that really mean? Well, all that's saying is that we treat people and not as numbers and not as the disease, right? And we recognize that there is a complexity there that needs to be addressed in their hospital stay and as they transition out. This was first recognized in law in 1991, where we said, okay, patients get to make some decisions about their health care. We will not dictate that full course. In fact, they can say no. And they have the right to decide what their health care might look like in the future should something bad happen in the form of advanced directives. Contemporarily, these concepts have been embraced across disciplines and across the medical care pathways. And in the Society of Critical Care Medicine, there have been a few tenets of high quality palliative care that have been delivered. So of import, we want timely, clear, and compassionate communication. When we talk about clinical decision making, we're going to focus it and center it around the patient, their caregivers, families, and people who are important in their lives. We're going to make sure that we're maintaining comfort, dignity, and personhood. Again, treating the human being and not just the disease. And that we allow access for loved ones and family members to participate in that care pathway as the patient would want. Now, to achieve all of those things, they gave a timeline. It's short, right? Day 1, day 3, day 5. Why? Because we are not talking about outpatient care. We're not talking about the family practitioner who used to make house calls who cared for 3 generations. We are developing relationships in very short periods of time and trying to build trust so that we can have a collective pathway for care. This is also supported by the American College of Surgeons. This is published this year for the trauma population, and again, 24 to 72 hours. Because what we're trying to avoid is something that looks like this, where we're providing aggressive care right up until the point of death without real meaningful potential for survival and quality of life. What we hope for is something that looks more like this, where we acknowledge where our success, know when what we're providing will not achieve the goals of the family, the patient, and then transition care, continue to care for our patients, and help them achieve the best quality of life they can with the time they have available. So 30 years ago, these were the statistics. We had up to 20% of people dying in our ICUs, and 1/3 of Americans were dying in the hospital. Most people hadn't thought about, or if they had, hadn't documented their wishes. And unfortunately, our statistics haven't changed all that much, making our issues here all the more pertinent and relevant. So what's the future of palliative care? To look forward, I really do believe that we have to look back. This is Cecily Saunders. She is the founder of the hospice movement in Britain. It's where it started. In the 1960s, she said that patients really needed to be cared for in a comprehensive fashion. And interestingly, she had expertise as a nurse, as a social worker, and then as a physician. So she had a unique perspective in that she had training in all of these fields. Most of us do not. And we rely on one another, a team, a big team, to care for our patients. And each and every person in this care pathway need to be involved in providing whole patient care, keeping the patient, their family, and caregivers in the center of that conversation. Because it's really about the team. They are your most important resources. So how do we achieve this? One, we identify advocates across the care team. So that means nurses, physicians, speech pathologists, physical therapists, people who are motivated and want to provide comprehensive care to their patients and to think about strategies to achieve that. We need to figure out how to allocate our own resources in our own centers. In 2013, the ICU group put forth a concept of triggers, identifying patients who are at the highest risk for poor outcomes or death. Now, at the same time, they also released a guide recognizing that every institution is different, that whether or not we have specialists in our midst as the physician or the nurse, maybe there are people who have some end-of-life palliative care training, specialization in pain and symptom management. Do we really need to call a palliative care consult to achieve this? Or are there ways that intrinsically, in a form of primary palliative care, we can meet the needs of our patients without exhausting the resources available at our institution? And they gave guides for care delivery, worksheets, suggestions, and references, which are all available and really a wonderful reference for trying to implement these kinds of practices in our own home institutions. We want to assess early and prognosticate. So you may be familiar with this question, the surprise question, right? So from the door, from the people who facilitate cleaning the room, if they can tell that your patient probably won't survive his hospitalization, that should be relayed to the patient and the family. And sometimes this feels a little nebulous, like predicting the weather, but the reality is we have a lot of resources. We have our clinical experience, we have colleagues, we have evidence-based data, and we have a whole compendium of tools that help us determine who is likely to have a complication or die in a hospitalization. You just have to pick the ones that you feel comfortable with and use them frequently so you know their benefits and their deficits. I would be remiss if I didn't mention frailty, which is a growing measure of outcomes, and it crosses all disciplines. It's an excellent predictor of morbidity and mortality. And again, there are many different ways to measure this, but you have to find something that works for you. This is from the American College of Surgeons T-QUIP guidelines, and it's fairly simple and straightforward, something that could truly be implemented. You want to empower your team to facilitate acquisition of key information, because there are a lot of people who spend time with patients and with their families. In the American Nursing Association call to action, they rightly noted that nurses are excellent listeners and are at the bedside listening and communicating with patients. They serve and can serve as wonderful advocates if they are empowered to do so. Collecting information like who are the key players who really need to be present for conversations about goals of care. What was life like prior to hospitalization? Dignity therapy, a concept where we just talk to patients. What's important to you? What do you hope for? What do you fear? And how can we help? And then to help us identify also hurdles to communication. Are there social issues? Are there financial issues? Are there key players who aren't present, who need to come and be at the bedside to engage in these conversations? Because what we want to avoid is conflict down the road. And then with all this wonderful information, we need to make sure that other people can access it. So we need to create accessible documentation where people who are acquiring this information can make a repository so that everyone can share. That can be in the EMR, that can be on morning rounds because you include other members of the team to participate. That can include multidisciplinary rounds, once a week, twice a week, 3 times a week, where you bring together the entire team to talk about patients and make sure that our trajectory is consistent. And then you bring the key players of our care team to the family meeting to serve as advocates for patients, to maintain those relationships that are being fostered at the bedside. We want to develop plans that are realistic and that are shared. Patients want to hear from us. They want to talk about end-of-life care issues. When we do that, we need to use tools. Just like placing a central line, a conversation has structure. And we need to maintain that structure so that we are consistent with all of our patients and with our message. And note that more than half of this conversation is actually the patient or family relaying information to us, not us talking at them. When we talk about code status, we must remember and relay that DNR, DNI doesn't mean do nothing. We're still providing comprehensive care. When we talk about code status, it's not set in stone. It should be revisited every time there's a change in clinical status. We shouldn't wait till there's an emergency, and we should be careful about our language. If CPR is not going to be effective, why do we offer it? Instead of saying that we're going to withhold that care, what we should do is explain why we don't think it will be of benefit. Because people don't like things withheld from them. But if you explain, they will understand why you don't want to offer it. If someone is not full care, full code, we should be filling out forms like a post, which allows us to relay the comprehensive conversations we're having in the hospital out to our colleagues in the community so that we continue to honor our patients and their wishes. And we need to communicate to everyone involved. Because if we don't deliver a consistent message, we create doubt and we lose trust. Lastly, we need to continue the process of education and identify resources for all care members. And these are some that I really like. The first, the Center to Advance Palliative Care. This is a national repository of information. In the majority of university hospitals across the country, this is available to all care providers because they already have an account and a membership. We have it here at UCSD. It's just about knowing that you have that resource. It includes education tools. It includes forms, documents, example order sets, billing information. It is extremely comprehensive. Within that is the Improving Palliative Care in the ICU project, which is specific to our intensive care population. The National Consensus Project for Quality Palliative Care has a really nice set of clear guidelines that we can try to achieve. LNEC, across the country, it's a uniform education program for nurses to further their understanding of palliative care and whole patient care delivery. So there are lots of resources. Explore them, employ them, and then distribute them to your colleagues so that everyone is on the same page and that we all understand what the goal is here. So, in summary, what we're really talking about is comprehensive whole patient care. You can call it palliative care. You can call it really whatever you want, right? Palliative care has sort of, I think, changed its focus and its branding, but at its core, it's still the same thing, right? It's really about caring for the entire patient. The pathophysiology is only a part. Our new guidelines are very, very clear about our timelines. It's important because we have very little time with our patients and we need to build that trust through communication, through collaboration, and partnerships. Questions? Okay.
All right.
Have a great day.